Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you to my interview with the authors of an important and interesting article from the April 2025 edition of the Journal of Rheumatology. Today, I will be speaking with Doctors Renato, Ferrandiz-Espadin, Jean Liew, Maureen, Dubreuil, who are speaking on behalf of all the authors of our featured article titled Disparities in Time to Diagnosis of Radiographic Axial Spondyloarthritis. And I want to thank the three of you for taking time to speak to me and for our listeners on behalf of the authors and discuss the findings of this important paper. So with that, we'll start. Can you please give me a little background for the rationale that led to this work?
Yes, absolutely. So I think one of the biggest challenges with radiographic axial spondyloarthritis and with axial spondyloarthritis is that many of our patients start with a non-specific back pain. And because the back pain is so common, it's often doesn't really get the proper workup and follow-up. So that actually leads to patients getting a diagnostic delay of maybe about 7 years, where the patients may have seen other providers and really never heard the word r-axSpA or radiographic axial spondyloarthritis. So besides that, this is not just back pain. Also, patients experience inflammation outside of the spine. Because of that, sometimes they get to see an eye doctor and they tell them they have uveitis, a dermatologist, they tell them they have psoriasis. So they don't really connect the dots to tell, hey, you may be having r-axSpA. So when it comes to this delay that we have by the disease itself, then we ask ourselves that historically this disease have seen a lot of delays and a lot of biases, especially with patients that are Black or are Hispanic, Latino patients that tend to have worse severity of disease and higher inflammations. So we noticed that putting that into account and patients also experiencing barriers, systemic barriers in terms of healthcare access, provider knowledge, and some other social determinants of health that they are lacking, this is a combination that leads to a delay in diagnosis. So I don't think for r-axSpA we talk about the delay that is caused by the social disparities enough. And these patients really need to have more attention. So I truly think that the main reason we did our study was to really see what can we do better, not just from the diagnostic part, but also on how to make the patient closer to healthcare access and to have a prompt diagnosis.
Anything you want to add? Good. Okay. So with that, what was the specific aim of the study or aims?
So with what I say, we wanted to tackle a big question. So are there disparities in r-axSpA, and how long it takes for someone to get diagnosed with radiographic axial spondyloarthritis, considering these factors as a cause of the delay or as a significant contributor of the delay? So we already know that the average diagnosis is about 7 years, but could sex, race, ethnicity, or other social circumstance really make this diagnosis even prolonged? To get those answers, we aim to analyze data from the Boston University Medical Center to see if these patients have delays in their diagnosis given the fact of their social background.
Okay, which leads to the next obvious question. Can you please, for our readers, listeners, go over the methodology in more detail?
Yes. So for this study, we use the electronic healthcare records from the Boston University Medical Center. that approved this study. Over the period, we went through the data over the period of 2000 to 2022, and we chose the hospital, and we believe the hospital, it's a great place because it really serves a very diverse and underserved population, with 70% of our patients saying that identifying themselves as people of color, about half are insured through Medicaid, and a third part of the patients also not speaking English as their primary language. So I would say it's really a big representation of the country overall. So that's what I was really excited about our project. And to ensure that from the EHR we get a rigorous and standardized data collection, we use an observational health data science and informatics, also known as Odyssey, that it's a platform that has been used in some previous studies, and it's actually a very exciting platform because it allows us to get a uniform coding system, a uniform data in order to get transparency and consistency in our results. So we identify patients with the r-axSpA diagnosis by the ICD-9 and 10, and then we require them to have at least one patient visit a year before their diagnosis, allowing us to capture the healthcare journey and allowing us to have the time to get all the information and all the social background from each patient. So what we look in our variables, well, once we had the diagnosis, was seen by 2 independent rheumatologists to make sure that the cohort was accurate. And then we explore the variables of sex, race, and ethnicity, the social needs that we assess through a questionnaire called the TRIVE, that is a questionnaire developed at the University of Boston before in 2019, that it's a kind of a validated social determinant of health questionnaire that explores things that patients may face, like housing instability, food insecurity, transportations, issues, and medical affordability, all of which impact healthcare. So it's like a 10 questions questionnaire. And I would say that it's important to notice that we don't really have like a gold standard to measure social disparities. So we actually use this tool that was validated, and we think also it's kind of exciting to see if we can do it better in the future. But our main outcome again was that we wanted to know how long it took from a patient's recorded back pain or related symptoms once they came to our healthcare system to their official r-axSpA diagnosis. And we ended up using a survival model called the accelerated failure time model that also help us estimate the delays in diagnosis. So I just want to emphasize that we do not explore the time since the patient got the back pain itself that could have been subjective to the patient saying, oh, this was 3 years ago, 2 years ago. We just address the delay once the patient arrived to our healthcare system.
Oh, that's interesting. I was going to ask you that question, so it's time to referral. Okay. And you really went over the population. You want to add anything? Any of the other people?
Yeah, I would like to add a little something because this population is really different from the people we see included in clinical trials of axial spondyloarthritis, who are generally 90% white and affluent. And so this study really adds some helpful data that can, real world evidence that can be more generalizable than what we see in potentially in trial participants.
Right. Yes, absolutely. And so with that in mind, would you like to summarize what you did find?
Yes. So we initially identified 661 patients with the diagnosis of radiographic axial spondyloarthritis. And from them, after we apply our inclusion criteria that I mentioned, to have all this data of sex, ethnicity, race, and the documented social disparities, we ended up with 404 patients in our final cohort. So what we found here is that the average age was 49 years. Almost 40% of them were female. 25.5 of those patients, of all our patients, identified as Black, 43.4 as white, 14.1 identified as Hispanic or Latino, and then 31% either were from Asian, Middle Eastern, or native Hawaiian race and ethnicity, but a good amount of them didn't report their race. So it was a total of 31% that it was really in that small group, or patients who do not reported their race. So a key aspect of our study was also, as I mentioned, examining the impacts of social determinants of health. And we found that 34% of patients had at least one documented social need, such as housing instability, food insecurity, or difficulty affording medications. And among this group that had the social need, it was 36% who were Black, and 32 reported another or an unknown racial designation. So the delay itself, talking about the delays, we saw that patients who are in our cohort, patients who were older than 45 years tended to have a prolonged diagnosis, a prolonged delay in their diagnosis, which makes sense. Most of our diagnostic criteria have that 45 cutoff. If you were a woman, maybe you will have a prolonged diagnostic delay. And if you were from Black or Hispanic or Latino, Black race or Hispanic or Latino ethnicity, compared to white patients, you did have a diagnosis in delay. And as well, patients who presented a documented social need. And after we did our statistic study with the accelerated failure time model, we saw that we have an increased delay in diagnosis of up to 21% in those patients who presented a social need. And since the average time to diagnosis for those without social needs was around 34 months, it would mean that the patients with social need experienced an additional 7-month delay in receiving their diagnosis as patients who did not present a social need. And this was even after adjusting for age, sex, race, and ethnicity.
So I just want to be sure I understand for our listeners. We really, these months are not months, as you pointed out, I think, of time from patient diagnosed back as they reflect to the physician on your study. A back pain per se, it was actually time of referral to the university hospital. Is that correct?
So
Someone want to answer?
it was time from the first documented symptom, so that generally includes a billing code for back pain, to the diagnosis of axial spondyloarthritis in the medical record.
In the medical record, right. Mm-hmm. So if they had seen somebody 5 years earlier with back pain, you would not necessarily have been able to code that diagnosis because it wasn't in your medical record. I just want to clarify for everybody, because some of this is 35 months is short from time of back pain in most study. I just want to make sure everybody understands that.
That's right.
Okay. Yes. Again, it seems they were on our system. Before that, patient may have had years with back pain without a diagnosis.
No, I understand. On the one hand, just philosophically, it makes your data accurate to the sense that you can actually document, but it changes our thinking a little bit about the time of onset of back pain or time to come into your system. But the plus and minuses for both, but it still makes it very interesting. And so what do you feel then are the implications of the study for future care of your patients?
Yes, so I think that our study really tells that social disparities have a significant role in the time to diagnose, and also biases that we have had as physicians for many years, biases in the guidelines have led us to maybe not diagnose patients just because of their race or of their ethnicity. So this is important because if we realize this as physicians, then we may be able to say, I shouldn't be biased by the race, I shouldn't be biased, and I should explore more about the patient's social determinants of health to actually see if this is a patient that has a back pain, and I can follow up with that back pain, and the patient will actually come back to your office and get those studies done. So I think that addressing these disparities requires targeted education for healthcare providers, enhanced referral pathways, and maybe a more inclusive clinical research to ensure that we have equitable and timely diagnosis and treatment for all our patients with r-axSpA.
Would you like to add anything, Maureen or something? No? Okay. My last thing, is there anything the three of you feel we may have missed in this from the implications or any part of the study that you feel would be important to the listeners?
I think that one of our key things and one of the messages I would like to share with everyone is that a key issue in r-axSpA is that we need to optimize and improve the prompt diagnosis of r-axSpA itself. And I know that with all these changes in like this new recent study that will be out, that is the classification of axial spondyloarthritis inception cohort, the classic study done by the Spartan, who is going to face the 2009 criteria that we usually use for r-axSpA. What we want is that everyone is happy in how to diagnose r-axSpA, but I think it's also important to make primary care providers realize and feel comfortable with the diagnosis of r-axSpA. So while we are improving our diagnostic criteria, in the end, these patients will first show up in an urgent clinic, in a primary care setting, and if we try to facilitate the information through podcasts, through social media, then that will allow them to be more aware of this disease and also to unbias themselves from this disease. So I think that is also something important that I learned during this study, and I want to thank Boston University for allowing us to do such a great study and trying to generate some impact on this disease.
Speaking as the Canadian for a moment, and I won't even address that we're not going to be the 51st state. Just want to make that clear. So, but seriously, be interesting because, you know, we talk about bias. You were mentioning with bias, it's not necessarily a bias from social economic. It could be access to healthcare as opposed to intrinsic bias. And you sort of mentioned that follow up. Are we following patients at the same length? It would be interesting to compare findings of your study to a system, Canada or many other universal access to healthcare systems, and see how much the social, economic, etc., that you found racial ethnicity would hold in other multi-ethnic countries. But it really is important, then it would be, which would come back to an important issue. Do we have underlying biases against people that we're seeing, which I'm sure we do? We'd love to think we don't, but I'm sure we do. Or is it just a fact of social, economic, and other determinants of health that we don't address adequately? But that's more philosophically. Yeah. But I do want to thank you for reviewing the findings and the implications of the care for patients with radiographic axial spondyloarthritis. And for our viewers and listeners, please read the whole article titled Disparities in Time to Diagnosis of Radiographic Axial Spondyloarthritis. And there is an accompanying editorial titled Disparities in Diagnosis, a Call for Equity in Radiographic Axial Spondyloarthritis Care by Dr. Shaosin Liew and Jonathan Kay from UMass Memorial Medical Center, Worcester, USA. Both the original article and the editorial available at the journal's website at jroom.org and in the April print edition of the journal. But I want to thank everybody for joining us, and hope we'll all come back next week when I speak to the author or authors of article particular interest from the May 2025 edition of the Journal of Rheumatology. And if there are any comments, questions, please let us know on X at jroom or by email manuscripts@jroom.com. And thank you again for listening.